The third talk, the second speaker is on her way. So the next talk will be given by Dr. Vijay Hadda. He's already given a talk, so I won't introduce again. He's a professor of pulmonary medicine from AIIMS, New Delhi. Dr. Hadda is the coordinator for the ICMR's network of pulmonary fibrosis. He will be talking about orphan ILDs.
Good afternoon again. So, I think this is a little more difficult topic. Orphan, everybody knows, nobody except him or her. So here it is ILD, nobody is accepting. Neither patient to never expect or accept, physicians also, pharmaceutical company also, and probably the decision makers also don't consider them as an important entity. So if we see the definition of this orphan disease, the term orphan disease means that almost nobody cares for the patient with the disease, and that no or little research has been undertaken to improve the diagnosis and to develop and commercialize drugs to treat the condition. So you can understand the gravity. Most of the time these diseases are rare, but it's not true that only rare disease will be orphan. Sometimes these diseases can be common also. For example, in low-income country, they have given example of trypanosomiasis in South Africa, which is very much neglected, although that is a very common problem there. In Indian publications, this study by Sejal, they have shown on the left side, if you see, there are few uncommon diseases. For example, pulmonary alveolar proteinosis, cystic lung diseases, pulmonary alveolar microlithiasis, and so on. These are diseases, but they are affecting probably less than 1% or 0.1% kind of whole population of ILDs. So in next few minutes, I will try to give just a running overview of these diseases. Cystic ILD, I think cystic ILD is one which we come across once in a while, maybe once in 6 months. And then we keep on struggling in which phenotype or what kind of disease it is. So although origin wise this cyst can be due to infection, congenital, neoplastic, smoking related, some genetic disorder, and so on, but for as a pulmonologist or ILD specialist, we are more concerned about few diseases. Among these, Langerhans cell histiocytosis is the commonest one, which is we are concerned. This is usually seen in young smokers. In early disease, the patient can present with nodules, which are more in the upper lobe. Usually bases are spared. They will be random in distribution. They will be irregular margin. And as the disease progresses, the nodule will decrease and they will be replaced by the cyst. These cysts are again the upper lobe dominant, relative sparing of lung bases. They usually spare the medial tip of the middle lobe and lingula. They will be bizarre shape as shown here. They are bizarre shape as we will see in the next slide, where the different diseases, their cysts are totally different. And as the disease severity increases, the number of cysts will also increases. So this is because the next disease, which is in young female, the lymphangiomyomatosis, this is basically a disease of young reproductive age female. It is in this disease the destruction is led by the LAM cells, which lead to formation of cyst, and these cysts are diffusely distributed, and the intervening lung parenchyma, we will see, that will be normal. Usually this jectophrenic recesses are also involved. Extreme FICs are spared as compared to the previous disease. There may be pleural effusion. If it is chylothorax and cyst, then this is almost confirm the diagnosis in young reproductive age female. And then you can see the abdomen, and if it is showing some a tumor over kidney, then diagnosis can be shown. So this is the distribution of cyst. You can recollect that the previously seen cysts are like this. They are bizarre shaped, but if you see these kind of cysts, they are very clean, distributed everywhere, and distribution is also different. And once in the cases where the tuberous sclerosis is there. There can also be, LAM can be there. In those cases, there can be nodules. Otherwise, in LAM, usually nodules are not there. Coming to the next disorder, it is LIP. Usually it is benign disorder, but in 5% cases, a patient can develop lymphoma. They are also seen in association with Sjogren, SLE, HIV infection, hepatitis C, and so on. Most common involvement is in 3rd or 4th decades, is seen in women, and it may be idiopathic also. When we see the distribution, it is lower lung predominant. It is associated with GGOs and confederations. Cysts are often perivascular, may have internal septations, and usually accompanied by interlobular septal thickening or reticular opacities. And once we treat, GGO will go, but cysts do not go. These will persist. So you can see this. So there will be GGOs and there are cysts. So if this kind of presentation is there, you are very sure of the diagnosis. The fourth one is Birt-Hogg-Dubé syndrome. It's basically one, if there is a classical triad, then diagnosis is easy. For example, lung cyst, skin lesion in the form of fibrofolliculomas, or renal tumors. But they are difficult to find out because usually we don't screen, but if you screen and found, then the diagnosis can be little easier. The distribution of cyst again is lower lung dominant. The cyst may be multiseptated. The intervening lung parenchyma will be normal. The cyst usually abut the pleura, and there may be near pleural parenchyma. And lung biopsy, we need to remember that lung biopsy usually not helpful. Instead, we should do the skin biopsy, and if we can demonstrate fibrofolliculomas, then diagnosis is established, and we can do the mutation of the gene. So you can see here the cysts, they are touching the mediastinum usually, and there are skin lesions, and if you see down, there is a tumor around the kidney. So if this kind of triad is there, then diagnosis is straightforward. The another important thing is these patients are at risk of development of renal tumor, so they need a screening which is started at age of 20, and then if there is no lesion, every 3 years we need to do the imaging. So in this slide, I have summarized all the cystic lung diseases. If you see PLCS, this young smoker, the patient will be young smoker. The cyst will be in upper lobe. Lung basis and CP angle are spared. They will be jar shape. In LAM, it is seen in female reproductive age group, diffuse cyst, juxtaphrenic involvement will be there, cyst will be round. And if you see LIP, again, this more common female, lower lung dominant, perivascular cysts are there. Additional feature, you can see the GGOs and septal thickening, whereas BSD is usually in 20s, 30s. If there is triad of skin involvement, renal, and then cysts are there, then diagnosis little bit easier. Lower lung dominance is there. Cysts are usually oval shape, have septation, and abut the pleura. Coming to the next orphan disease is pulmonary alveolar proteinosis. In this diagram, I have shown the metabolism of the surfactant and the defects. Usually the surfactant is produced by the type 2 pneumocytes, and these same cells also secrete the GM-CSF. So GM-CSF stimulate these macrophages, and if there is a problem with the signaling, then it lead to the primary PAP. But if there is problem with the macrophages, then it is secondary PAP. It may be because of some infection or like that. And if in congenital, there is the defect in the surfactant itself. So usually the CT is so classical that once we see this crazy paving, differentials are very, very limited one. These are the few differential which we should consider whenever there is crazy paving: pulmonary edema, alveolar hemorrhage, PCP, then this BSE or acute exacerbation of ILD. So these all can be easily dissected out clinically. So if crazy paving, then most of the time diagnosis is easy to consider. And if there is pleural effusion, mediastinal node, or evidence of air trapping, pulmonary nodules, these all indicate against the diagnosis of pulmonary alveolar proteinosis. And if we do BAL, and if we see this kind of milky kind of fluid, diagnosis is almost certain. And if we do the microscopy, it can show a classic PAS positive, as in blue negative kind of a microscopy, and these is because of the cell debris. Usually lung biopsy is not required, but when the ball is not classically milky white, in those cases we can do maybe TBLB, and that can give the diagnosis. Sometimes a patient also required VATS guided biopsy also. This yield which I have shown is not for PAP, this is overall ILDs, but in those ILDs few cases of PAP were also there. So don't think that in PAP we are going to do this lung biopsies. And once we have made a diagnosis of PAP, we need to further classify it. So most of the time it is autoimmune or primary PAP, where if we see this anti-GM-CSF antibodies, which is not done in India, but there is Cincinnati Hospital in US, most of center I think sending sample there, and if it is positive, it's almost 100% diagnostic for autoimmune PAP. So this is the algorithm, how we proceed once we have reached the diagnosis of PAP. Basically we want to divide, classify it secondary PAP, autoimmune PAP, hereditary, congenital and unclassifiable kind of PAP. So depending on various tests, whether first we will go for GM-CSF antibodies. If that is positive, that is autoimmune PAP. If that is not positive, then we see the GM-CSF level and signaling test, and based on that we divide into two. And BAL sometimes can give the secondary causes, for example infection, that can also lead to PAP. So based on this we divide, and based on that we try to start the treatment. So this algorithm, I will not go into detail, but most of the time these patients require whole lung lavage. That is the treatment of choice if patient is symptomatic and there is a significant physiological impairment in the either ABG or the PFT. So based on that we decide that patient require treatment. Whole lung lavage, that can be repeated also, and if there is a repeated requirement of whole lung lavage, then we can give and GM-CSF also, either inhalation route or by subcutaneous route, and there is, I think recently paper is also published for the same. Next comes the pulmonary alveolar proteinosis microlithiasis. This is basically called with different names at different times and different timelines. Most recently 2007 when the mutation is identified responsible for this. So in this disease there is accumulation of hydropeptide microlith within the alveolar space. So overall approximately 1,000 cases have been reported till now. It's a autosomal recessive disorder. Usually the familial incidence is 30 to 35%, or most of the time the patient is in early 20s, but the higher age is also reported in the literature. There is no gender prediction for the disease. So the mutation is in the sodium phosphate co-transporter. The gene name is given here. So it causes the transport of sodium phosphate co-transporter, and when it is a problem, so it leads to accumulation of this. So how the patient present? The patient usually can be asymptomatic, but once disease is progressive, then they will develop respiratory symptoms. And in many times, there will be clinico-radiological dissociation. Once you see the radiology, there will be lots of shadows, but patient may not be symptomatic. On investigation, you can find there is a reduction in DLCO. PFT in early stage may be normal. In later stage, as other ILDs, it will show restrictive pattern. 2D echo can show signs of pulmonary hypertension. Serum calcium phosphates are normal. And there are few research which are trying to find the biomarkers, and two of these are presented here, which looks promising one. So this is the radiology. So you can see easily that there micro nodules are there. So if this kind of image is there, is quite classical of PAM. Prognosis is not good. So and the important thing is, once we have diagnosed this, we need to screen the family for this mutation. Treatment is again non-specific. If patient is requiring oxygen, we give that. Otherwise, we need to vaccinate just like other lung diseases. We offer pulmonary rehabilitation, and if required, patient should be offered lung transplant. And there are few drugs which with questionable benefit. So there are few case reports or kind of things are there. Coming to pleuroparenchymal fibroblastosis, so this is again a rare ILD, and this term was first used in 2004. So basically, what is PPF is upper lobe subpleural fibrosis, which involve both visceral pleura and subpleural lung parenchyma also, and there is a prominent elastosis of the alveolar wall, fibrous thickening of visceral pleura. So this is the different component of PPFE. So if you see this image, there is a pleural involvement, and subsequently subpleural parenchymal involvement is also there. So it is just like a pattern, and this pattern has been described in almost 8% of IIPs. And if we see the lung transplant data, they have shown that in approximately 25% of fibrotic ILD, which are registered for lung transplant, they have this pattern. And those who have already undergone lung transplant, approximately 0.2 to 2% of patients have shown this pattern. In hematopoietic stem cell transplant patient, approximately 7.5% of patients have shown this PPFE pattern. Pathogenesis, we don't know. However, there are few risk factors which have been proposed. The chronic or recurrent respiratory infection, especially fungal or NTM infection, and sometimes the exposure of this asbestos, aluminum or organic antigen can be a risk factor. For diagnosis, radiological findings are essential. Histopathology, although is gold standard, but it's not mandatory for diagnosis. Many times, if it's a classical CT and MDD based discussion, we can make a diagnosis. Once the disease is progressive, the prognosis is very poor. Usually the median survival is approximately 35 to 96 months. There is no standardized treatment. Lung transplant is only proven benefit. The next comes the idiopathic pulmonary hemosiderosis. So it's again rare. It is seen in 1 in 1 million child, and sometimes it is also with gluten or cow milk hypersensitivity. So that is when it combined, then is a kind of syndrome which is named as Lane-Hamilton syndrome. Diagnosis is usually by exclusion, and after once patient present first time, survival is approximately 15 years after that. So usually child come with recurrent episodes of kind of a DAH. So this is one of the differential for DAH, and 3/4 may develop pulmonary fibrosis. Patient will have iron deficiency anemia, and optimal therapy till date we don't know. The treatment therapy are usually, because the patient present with DAH, so many times we treat like autoimmune DAH. Coming to Hermansky-Podolak syndrome, it's again rare disorder affecting 1 to 2 cases per million, and the classical feature are oculocutaneous albinism, some hemorrhagic diathesis due to platelet dysfunction. In some cases only pulmonary fibrosis or glomerular colitis can also be seen. It's a genetic disorder, and basically this is a disorder where there is a problem with the synthesis, trafficking and homeostasis of lysosome. So because of this can be there. So there is 8 classical forms. In few forms pulmonary fibrosis is common, and antifibrotic has been used, but because it's a rare disease, so we don't know how much is the benefit or harms are there. So there are some genetic disorders are there. I have just mentioned here. I don't know what these are, but they are described in the literature that there are few diseases which are associated with genetic. They consider genetic origin. So for theoretical purpose, we need to remember. But most of the time, these patients will be young, and there may be family history. So if any patient who is coming with ILD in young age, especially with family history, then we should start thinking regarding this ILD with genetic origin. So the take-home message is many subtypes of ILDs are rare, and there is not much research about those diseases. Even diagnostic algorithm, treatment protocols are not known. But awareness is needed to make a diagnosis and appropriate therapeutic decision, because we don't know their treatment as such, and they should not get an appropriate treatment. For example, where immunosuppressives are not required and we are giving unnecessarily. Similarly, antifibrotic which are not required and we are giving unnecessarily. So if somebody is really interested, this is a interesting one article is there in this European Respiratory Review, and then there is a monogram is also there on rare ILD in this one. Thank you everyone. Any question or comment? So
They're all
I don't
asleep.
know.
No questions, I presume?